Attendees are in listen-only mode.
Welcome to the Essential Substance Abuse Skills webinar series. I'm Karen Summers and I'll be administering today's webinar. Today, Bob Rarrett will be speaking on treatment knowledge. This training series is brought to you by the National American Indian and Alaska Native Addiction Technology Transfer Center, or ATTC. The National American Indian and Alaska Native ATTC is one of 4 national focus centers which serves the ATTC network. The ATTC network is a nationwide network made up of 10 regional centers, 4 national focus centers, and a network coordinating office. The map on this slide shows the states served by each of the regional ATTCs. To learn more about our center, the network, or your regional center, please visit our website. This series is designed to be a broad overview to assist in preparing for written alcohol and drug certification examinations, to enhance existing knowledge, and to improve overall competence and treatment outcomes. Please be aware that this series is not meant to stand alone, and previous education and training is necessary in order to pass alcohol and drug certification exams. We recommend that if you are preparing for an exam that you seek additional preparatory help and let this course be one of many tools you use to prepare. Our next webinar in this series is scheduled for Wednesday, August 21st, where Kate Speck will present on basic counseling skills. In addition to this webinar series, we offer another series titled the American Indian and Alaska Native Behavioral Health Webinar Series, which presents on current topics of interest in the behavioral health field. The next session in our American Indian and Alaska Native Behavioral Health webinar series will be held on August 7th from 1 to 2 p.m. Eastern Time, where Harold Tarbell will be presenting using multiple techniques to facilitate strategic planning. For information on our webinar series, you can contact me at the email address or phone number provided on this slide. Our center is a NADAC certified educational provider, and we'd be happy to provide you with CEUs. The cost is $10 to do so. The CEU request form, along with a copy of the PowerPoint, will be sent to you within 24 hours of today's session. If you don't receive the email with the handouts within 2 business days, please let us know. In addition to the PowerPoint handout and CEU request form, a consent form and information about participation in our GIPR evaluation will be attached to the email you receive following today's webinar. We ask that you fill out the consent form and return it by either email or fax. If you agree to complete our evaluation, you will receive a link inviting you to participate in a brief online customer survey. This survey asks about your satisfaction with the event and will take less than 10 minutes to complete. GIPRA stands for the Government Performance and Results Act, and SAMHSA asks us to evaluate our events in order to comply with this act and provide improved performance assessment and accountability. SAMHSA uses the information collected by these surveys to determine how many people have attended our events, your satisfaction with our events, and how useful our events are to you. We hope you will assist us in gathering this information about our services by participating in our evaluation. Before we start today's webinar, I would like to give you a quick overview of the GoToWebinar system. To hide or expand your toolbar at any time, you can click the red arrow in the top right side of your window. To expand your screen, click the middle button in the top right-hand corner. You will be muted for the duration of this webinar. Please use the question chat box to share your questions and comments. Your questions will be visible only to me, the webinar moderator, and I will pass your questions along to the presenter at appropriate points in the presentation. We would also like you to be aware that this webinar records participant attention time. If you minimize the webinar or are working in another window, the system will record your participation as inactive, which may be reflected in the number of CEUs received. Today's speaker is Bob Rarrett. Mr. Rarrett has worked in the field of behavioral health for 20 years, and he is currently employed by the Ramsey County Human Services as the director of a 50-bed medically monitored detoxification center in St. Paul, Minnesota. Bob has experience as a clinician, clinical supervisor, senior manager, director, and executive director in a variety of settings. Please join me in welcoming Bob Rarrett.
Thanks, Karen. Help me find my screen. There we go. Hey, I think I did it. Okay, welcome everybody. And thank you for taking some time out of your day here to talk about this topic, and hopefully you'll find this helpful. I think what I'd like to do is go through the presentation and then leave some time at the end for questions and discussion. It's an interesting time to talk about treatment knowledge because of the many changes that are occurring in the healthcare system. So there's a lot of stuff that's going on right now that's promising and interesting, and I do want to just mention some of those things as we go through this, but I don't want to stray too far from the topic, from the purpose behind this webinar, which is to help with preparation for the IC and RC exam. So I'll try and stick to my slides here for the most part, but maybe make some editorial comments as we go, which I'm prone to do. So we'll begin here with the goals and objectives of this particular training. What is evidence-based and best practice, and what just happened? Karen, did you see a difference in the screen?
Yeah, Bob, it looks like if you can just reopen it in slideshow.
Oops, sorry. Okay. All right, I think we're okay. The Therapeutic Relationship and the Treatment Alliance, best practices, and co-occurring disorders. We'll cover all of these things varying degrees. I do want to make some comments about how some of these goals and objectives apply to some of the changes that are occurring in the treatment field, substance abuse treatment field. So what's evidence-based and best practices? This gives a description of what evidence-based practices are. I think the key elements of this are the ability to replicate key factors and recognize scientific journals. The issue of manualized treatment, I know when I was a beginning counselor, met with some resistance. The notion that you would have a manual that would guide the type of group or the session that you were conducting seemed a little bit like taking the practice out of the clinician's hands and putting it into a too restrictive sort of method of teaching or providing services. But over the years, I've become a very vocal fan of manualized treatment because, for two reasons primarily, because it allows different clinicians to provide a similar kind of group experience for clients. So if you had a clinician on vacation for a couple of weeks and someone else stepped in, they would be able to provide a similar kind of service covering the similar kind of material. And the other reason is for fidelity and just for monitoring and evaluating service. You want to make sure that you're delivering a similar and consistent type of group or type of session that has some common elements to it, regardless of who's doing it. Best practice is a method or technique that consistently shows results superior to those achieved by other means and evolves. Again, as a field, I really push for clinicians to open their minds to new ideas, look at the current research, look at the current promising practices, and say, how can we adapt this field to better meet the needs of our clients? We all know that we live in an ever-evolving world, and culture changes and trends change, and we need to be very adaptable, very flexible in how we approach addiction treatment so that we're paying attention to the science and also paying attention to how people change, why they change, and how things like environment and culture impact those areas. And a promising practice is listed here. It's those things that are maybe not yet well researched, but show some indication that they may be effective, and then finding ways to realistically translate those practices to a real-life treatment situation or treatment program, so that there's that bridge between research and practice. And we find out from both how to continually evolve and how to continually adapt a particular promising practice to meet not just the research needs, but also the actual real-life needs of the provider. What's our goal for substance abuse treatment? To provide optimum opportunity for health behavior change and persistent and incremental improvements in the quality and effectiveness of substance abuse treatment, resulting in better recovery for quality recovery for more people. I think, again, a bit of an editorial, but I think viewing a person's need for substance abuse treatment as a part of their overall health care, and really viewing health from a broader perspective benefits us, those of us who work in this field, because we begin to see how those other parts of a person's life interact and influence their behavior and the way they think. Right now especially, we have an opportunity to improve treatment services and monitor outcomes. Monitoring outcomes is critical, and we have to do it, and we have to do it in a way that makes sense across the board. So, in other words, we have to have a common language in how we evaluate and monitor treatment services, so we have an understanding. Are we doing it are we having similar outcomes in Minnesota versus Florida? And if so, is it because service delivery is different, or is it because of population differences? And there are effective and cost-efficient treatments available for substance use disorders. Those are the ones we should be paying attention to and all trying to learn from. Again, being open to new ideas, being open to different approaches. If you're an old dinosaur like me, you tend to cling to old ways of thinking, even if they're maybe not the best way to do things. At least be open to the idea that there's a better or more promising way to effectively help people. So these are some of the evidence-based practices for addiction treatment. Cognitive behavioral approaches are pretty common. Integrated care is, again, in my mind, one of the things we need to focus on, involving primary care especially. Motivational enhancement therapy and motivational interviewing are promising approaches. Again, I think the fidelity of that model needs to be adhered to. Many of us think we use motivational interviewing and find that we really aren't quite adhering to what the model promotes. 12-step facilitation is always important and helpful. Contingency management or incentivizing clients through reward systems for positive health changes could be something like, I don't know, coming up with some kind of reward for a client that consistently shows negative UAs or some other means of maintaining abstinence or behavior change. Pharmacological therapies are very important, and I think an upcoming focus that we'll all be a part of going forward, and medication-assisted therapy, especially for opioid addiction and now to some degree with alcohol addiction. All of these things need to be a part of how we approach treatment, though, not anyone in seclusion. We have to think again of the person in the whole sense, and all of those things that influence their behavior and influence their health, and see how these evidence-based practices fit within that person's life, and offer them a menu of options for them to also choose from. This slide says evidence-based practices for adult or for alcohol treatment. I'm not sure it just specifically should apply to alcohol treatment, but in looking back, I would just remove the word alcohol and say treatment. Brief intervention, screening, brief intervention, and referral to treatment tool. SBIRT is something that I think physicians are finding is difficult to implement in their setting. That is, for them to provide a brief screening and intervention because of their time limits and the ability they have to set aside enough time to do this. But there are other healthcare professionals within clinics, within primary care settings, certainly within human service settings, that could do a SBIRT with a client. And it really involves not just the screening portion. It involves that few minutes where a person can sit down with the client, explain how the screening tool works, explain what it means, and then talk a little more about what that means and how that fits into the picture of their overall health and what seeking treatment for an addiction disorder might mean for improving their overall health, why there's concern, and that sort of thing. A motivational, if you will, a motivational brief intervention that way, and then a clear referral source, some number or the name of a few programs, something specific that you can give the client that would steer them in a direction that wasn't too confusing and wasn't full of too many options. But that's my opinion about that. But I think there are many options available in healthcare settings where SBIRT could be more effective and where people would have the time to properly use that approach. Integrated care, as I said before, involving primary care is critical. Addiction is primarily a brain disorder, and a lot of the behavior, or most of the behavior that we see, results from that primary brain disorder in combination with environment and social networks and things like that. But the integration of primary care into this field, or vice versa, has been something that I think either has been resisted for a long time or just hasn't been possible because of funding to involve docs and physician's assistants and nurse practitioners more. But I think we have to recognize and understand as professionals the implications for addiction being a brain disorder and how that impacts behavior, because we need to know that in order to adjust our treatment approaches to better match the physiological change that occurs during addiction. Motivational enhancement and motivational interviewing, again, I think are very good practices for anyone, really. We can use that in any part of our lives. But for counseling especially, to have that non-judgmental sort of Rogerian approach to listening to the client, expressing empathy, but at the same time being somewhat directional in how we guide the client in partnership with them, guide them in a direction that's likely to improve their health and improve their situation. Community reinforcement and involving community-based organizations that focus on recovery and focus on health is also, it's very important, and we really, I think, have sort of relegated them to the periphery of treatment, whereas I think we should bring community reinforcement and community-based providers or community-based forms of support into the treatment realm and really integrate that as a part of what we do, having peer specialists and whatever you might call them in your particular area, but peer specialists or community client advocates and that sort of thing, and involve them in everything that we do to the extent that makes sense for the client. Behavioral contracting can help to set some structure and put some guidelines for the client to adhere to, and gives them some additional, I think, investment in their recovery by saying, yes, I agreed to this, or to try doing this, without holding them, of course, without making them feel like like they're a failure or something if they don't follow through, but using it as a tool, of course, to help the client understand how adhering to a contract or a particular set of expectations might help them to change behavior going forward, as it gives them a bit more a structure, a bit more of a guideline for what they should or should not do for improving their health. And pharmacological treatments obviously are an upcoming, and medication-assisted treatment is an upcoming topic, or more of a topic that's being focused on more to address some of the physiological implications of addiction on the brain. Naltrexone, Suboxone, buprenorphine, methadone, things like that. I think someday you'll be watching the evening news, and instead of medications being advertised for depression and anxiety and every other imaginable disorder, I think you'll start seeing some that specifically address addiction, although there's pros and cons to that as well. Evidence-based practices for adolescents. I've worked with kids in the past quite a lot actually, and have done some research projects around family therapy and multifamily therapy versus treatment as usual. I think involving the family as much as possible has shown some positive outcomes, and I also think what we've had to do over the years is to develop age-appropriate motivational approaches without taking treatment approaches that have been designed for adults and trying to somehow morph them into a program for adolescents, but rather really study the developmental stages of adolescence, the brain science of adolescence, and develop motivational approaches along the lines of that specifically, and not trying to take adult models and somehow water them down or change them to be appropriate for adolescents. I think it's a disservice to kids to do that, and I don't think it's paying attention to the complex needs of adolescent brain development. I believe, I could be wrong here, but I believe the human brain doesn't stop really developing until about the mid-20s, and it's very much influenced by drugs, alcohol and other drugs, as well as many other things as we know. Biopsychosocial model looks at biological, psychological, and social aspects of a person's life. If you look at the ASAM criteria, obviously they focus on these areas in 6 dimensions. I won't cover that, that's a separate training, but you do want to again look at the whole person, how their biology is affected, what other kinds of co-occurring disorders might be present, and of course their environment has I think a tremendous impact on not just behavior but on psychological matters. So these things all interact, they all combine sometimes or contribute to the person's health in general and their behavior. So it's important to keep in mind again the whole person and what influences their health, what and who. And this is a big one for me, therapeutic relationship. Really, you can have the best training and experience in implementing treatment models. You can have all the knowledge in the world, and if you have a lousy relationship with the client, it's probably not going to matter. In my mind, it's critical, necessary to have a good therapeutic alliance with the client, and we'll cover what the definition of that is, the ethical responsibilities and the power distribution. Of course, you need to collaborate with the client, in my mind. You have to have a partnership there that allows the client to have input into their own recovery. I think, again, when I was younger in this field, there was a real tendency to outline for the client what they needed to do and by when. And we would present them with a treatment plan and say, here's what you need to change. And thankfully, we're not that way anymore, where we include the client's input. We try and tailor treatment approaches to their specific needs, and we do all of the client-centered things that we need to do, or we try to. But that's an area where we still have to remember we don't always know what's best for people. They oftentimes do know what's best for them given their situation. And it's an opportunity to meet with the therapist, build some trust and rapport. It's an opportunity for change through that relationship. There's sometimes opportunities as a therapist to present a way of thinking that wasn't immediately obvious to the client. And just by doing that, by expanding the options, by expanding the mindset of the client as to, oh, there are other ways of viewing this other than how I've been seeing it. And just that in itself, and that trust that evolves with the clinician, is enough oftentimes to really promote significant change, positive change for the client. And being an advocate, of course, for the client, being that voice for them. Oftentimes our clients don't have that in their lives. They don't have anyone really to stand up for them. What I found at working at a detox program too, it's a very short-term length of stay here, and many clients end up in a place like this, in a level of care like this, with pent-up stories to tell about very, very complex situations that led to their coming there. So their immediate presentation is that they're angry, they're scared, they're crying, and they have about 5 minutes or maybe 15, 20 minutes to explain all of that to a person. And it comes out jumbled, it comes out chaotic sometimes in the way they try and describe their situation. It's really important, I think, that we take as much time as we possibly can to listen and understand what frustrations and what difficulties that person is having, so that we can really do something to help them and be their advocate. But without listening and understanding and having some non-judgmental sort of acceptance of what they're telling you, then I don't think we stand much of a chance of really getting too much further. It's easier to do in a longer-term treatment facility because you have more time to spend and work with somebody. But in short-term kinds of interventions, whether it's an ER visit or a detoxification center or whatever the case may be, but when you have that brief amount of time, devoting as much of it as you can to understanding the client before making recommendations, before referring out and doing other things that could impact their life. It allows the patient, like I just said, to discuss emotions and previously undisclosed thoughts, to reinforcement suggestion, provide the patient with support and empathy, and models adaptive to interpersonal functioning. We can't, I think that last point, we just don't want to assume that a person has that same level of social skills or cognitively they are able to process things the same way as we are, that sort of thing. That would be my interpretation of that bullet point. The patient's development. Again, this reflects what I was talking about, but I think feeling the therapist is concerned is something that has to be a genuine reaction from the therapist. I don't think you can fake that, at least not with the clients that we serve. They've seen too much in their lives. Most of them have seen too much false empathy. I think they can tell, they're keenly aware, I should say, of how much of that empathy is genuine and how much concern is genuine. So just to be mindful of that. I'm sure you all have genuine concern and express genuine empathy, but we might feel it and not express it in a way that's genuine sometimes. Feeling the therapist is working with them, realistically optimistic, not promising the world, but at the same time looking at those aspects of a person's life where there is good reason to feel optimistic and where there is good opportunity for change, and really acknowledging when that positive change occurs. In my mind anyway, emphasizing that positive change has much more positive impact than highlighting any of the deficiencies or the negative behavior change. So obviously a more strengths-based positive focus seems to be more of a motivating influence, as you might already know. And gender and cultural effects are significant and often underestimated in terms of their impact on client motivation and client follow-through. Different cultures view illness and wellness differently. We don't all have the same definition of what illness means and what wellness means. We really need to try and understand individual cultural norms surrounding illness and wellness. Primary and parental role, domestic abuse cycle. These are things that impact client care, but gender and cultural effects, gender too, and cultural effects really have a significant impact on how a client views our efforts to help them. We're really operating, most of us probably are operating out of a Western-based notion of what constitutes illness and wellness. And because of that, we've designed a whole healthcare system around Western-based notions of health and wellness and illness. So stepping back from that a bit as we become more of a diverse culture in this country, stepping back from that and saying, how do you within your culture view this particular issue, and what is accepted and not accepted with respect to this particular issue, being substance use disorders or mental health disorders, behavioral health in general. Getting a good idea so that we become more palatable as an option for other cultures and for people with diverse needs. Gender, as I said, is a very critical part of that as well. So empathy, positive view of the patient's motivation, maintaining trust and confidentiality. The last one probably is key. Well, they're all three key, actually, to having a good outcome. So evidence-based best practices. Behavioral, cognitive, behavioral cue exposure, contingency management, coping skills, cognitive restructuring, relapse prevention, motivational interviewing, stages of change, and pharmacological. All of these things have been shown to be effective through research and have shown to be, we can replicate these models in various settings and have these kinds of approaches or models be effective. Within each of these, there's going to be variation, of course, based on culture, based on gender, based on other factors. But in general, these kinds of best practices are generally used and effective in their own right. So again, having a menu of options available, having a broader knowledge of how to combine and integrate these different sorts of best practices is also critical. There was, I'm sorry, take a second. There was a study done in the Netherlands, and it was on cue exposure. It had to do with clients sitting in front, these are clients with addiction, sitting in front of computer screens that flashed images in front of them at 1/1000th of a second for each image. So for the client sitting in front of the computer screen, excuse me, the screen looked blank. And what the researchers did was they flashed images of, say, neutral images such as houses, kittens, cars and things like that, and mixed within those images pictures of alcohol or some other drug-related paraphernalia. And they monitored the people that were participating in the research. They monitored their brains to see what kinds of activity took place while they watched this apparently blank screen. What they found was that when the person saw the image of drug paraphernalia or alcohol, that it triggered craving within the brain. They were able to measure that through, I think it's an SMRI procedure. It goes to show that, and I'm summarizing this very quickly, but it goes to show that sometimes there are cues that trigger craving within our clients that are not even visible to them through their naked eyes. So they're not even aware they're seeing something that's triggering craving, and yet it is actually in their brain being registered. Those images were an example of one study anyway, where that sort of thing was measured within the brain and showed part of the reason why when people relapse, they don't know why, and they can't really pinpoint what it was that maybe triggered that craving in that moment. Sometimes it's not a conscious recognition of what that thing is that's triggering craving. It could be just a flash of something that triggers craving. Craving tends to continue very, very strongly in the brain for at least, for alcohol anyway, for at least 4 to 12 months, while cognitive functioning or executive functioning is impaired for about that long. So you have a combination of executive functioning being reduced, the ability to plan and think logically and reason. That part of the brain is affected to where a person can't make really good decisions, while at the same time the part of the brain, the limbic system, is highly active with strong craving and sensitive to these kinds of cues. I mean to go on so long about that, but it was kind of an interesting study, and it was an indication of the kinds of things we need to pay attention to going forward. I think you're all familiar with the stages of change: pre-contemplation, contemplation, preparation, action, and maintenance. Again, people fluctuate within that, so we have to be, again, flexible with how we adjust our treatment approach to fit within that person's current stage of change and help them move then to hopefully another stage of change that's more in line with recovery. Theory. Well, that first sentence is self-explanatory and points to what I was talking about earlier. Nothing is entirely biological, but then I'm not sure anything is entirely behavioral. I added this, I think I added this last bullet point recently. Looking at behavior and environment allows for considerations of many determinants of health that influence change. It can, everything from socioeconomic status to culture to, and I'm blanking, but to other elements of a person's environment can have tremendous impact on their behavior. Biology plays a critical role, though, and it's been largely ignored, I think, in this field, or put on this, like I said, on the sidelines, whereas it needs to be brought into the discussion more often and more depth, so that we as clinicians who work with people who have substance use disorders and probably co-occurring disorders or maybe co-occurring disorders need to understand the biology behind that. Using the example I just gave with the study done in the Netherlands, it really is it's an eye-opener to us in the field to say biology plays a role and we have to acknowledge it and understand it better as professionals. But all of these things interact and play off each other, and it's really important, I think, to recognize that, if not understand it better going forward for all of us. 1 ounce of behavior change is worth 10,000 pounds of insight. Just a little catchy thing. Conditioning. Classical conditioning refers to the association between a stimulus and an involuntary or automatic behavior. You don't see this too much anymore. That's where I put in this little, in parentheses, the Netherlands study. I guess I meant to talk about it here and not earlier. But well, let me go through this. Classical conditioning is what it says here, obviously. And operant conditioning refers to an association between a voluntary behavior and a consequence. It'd be I could be wrong about this, but it would be my opinion that operant conditioning would include something like an abuse or some other deterrent to the behavior that you want to change. I maybe am getting that mixed up, classical conditioning and operant conditioning. Use the definitions here on the slides if I'm confusing you further, but use them for any further study for an exam for licensing. Self-monitoring provides a functional analysis of addictive behavior. Again, behavior is influenced by other factors, however, that go beyond sometimes a person's ability to manage or to stick to any certain behavior guidelines that they might know to be in their best interest. If somebody is dealing with intense craving and has a reduced ability to make good decisions for themselves, the likelihood that they'll be able to that self-monitoring is helpful in the sense that it allows them to recognize when those times and moments are and what circumstances maybe existed around those moments. But it may not always give them the ability to interrupt that pattern. It's helpful, though, to recognize what's going on with your brain and your body. So obviously, for the client's, from the client's perspective, it's good to have as much knowledge about that as possible. Not to use it as an excuse to continue a behavior, but to recognize it as an opportunity to be better prepared, to be as prepared as possible, given if those situations were to recur, to avoid a similar kind of outcome where a relapse might occur. And of course, thinking about how we, as individuals, process self-defeating thinking, how we identify high-risk situations, skill deficits, and things like that can certainly be helpful to a client and help them recognize those cues and risks for relapse. Help clients develop alternative coping skills, which is obviously important. And this is a quote by well, the reference is listed here. I'll take it for what it says and assume that's true. It's just an example of a self-monitoring feedback form. I think often it's helpful to provide a client with this kind of tool and help them with how to fill it out, how to think about it, and how they could apply something like this to their own lives. Maybe change the categories or change the language a bit, whatever fits with their particular way of learning and their particular way of viewing their own thoughts and behavior. How they could, in other words, evaluate their own thoughts and behavior in a way that makes sense to them. Cue exposure. I think probably we're all familiar with what this means. Relapse prevention programs focus on this sort of thing and the purpose, of course, is to try and help clients understand what, like we said earlier, what kinds of things to avoid, what kinds of things to help them cope with expectedly difficult situations. Let me back up. I think the one thing I would add to this is to broaden our approach to what kinds of things influence their behavior. So going back to that earlier discussion, just helping the client understand how this is one particular aspect of their health and that other parts of their lives influence their overall health, and helping the client to get a more broad picture of why things might have developed the way they have in their life. Help them understand how different kinds or different areas of their life interact to either increase the risk for substance use or the way things interact that could help them avoid future substance use or at least diminish their use in the process. Again, contingency management or incentivizing treatment is intended to reward positive behavior. It has shown, I guess, it has shown some legitimate efficacy in terms of good outcomes. And I've done this before in myself in treatment settings. It's not possible to offer financial incentives in a provider setting because we all don't have any money. But there are other ways, of course, to reward people for positive behavior, and sometimes it's not necessarily financial reward. It's other kinds of motivational methods or symbolic methods for acknowledging positive behavior. But it does show some promise, and if there are ways to do that within your own setting that you can think of, I would suggest it as a good method of reinforcing positive behavior. Again, the point of this slide presentation is to help people with the exam and to hopefully broaden our perspective a little bit. But I just want to caution, I think a lot of emphasis is placed on education for clients who are in treatment for a brief amount of time usually. And again, when we look at how well people absorb information and how they're able to take that information and translate it into something useful, it's really, it's coming into question as to how effective and how good of a use of time that is. I'm not saying we shouldn't do it. I'm just saying that psychoeducational groups and lecturing on a particular topic has a very limited outcome when it comes to changing behavior. I think it should be interwoven into other parts of what we do with clients so that we're providing other ways of dealing with addiction through behavior change and cognitive change, while introducing gradually some information that's relevant to whatever change effort you're focused on at the moment. So not inundating clients with, drugs are bad for this reason. They already know that primarily. If they don't know the specifics of it, they're probably not going to remember them anyway 2 weeks after the lecture's taken place. So written materials and supplements that help in line with whatever the care plan is and the existing or the current focus of that client's treatment plan at that moment, I think is more effective. It sort of combines education with other kinds of change. And then, of course, co-occurring disorders interfere sometimes with certain levels of functioning. So again, if we integrate care to the point where we have mental health professionals, substance use disorder professionals, and primary care professionals, not to exclude the community-based folks like AA and recovery-oriented support groups. But if we have a team approach, at least in terms of communication, then things like co-occurring disorders become more of a less of a fearful thing for people in this field to approach, because we're working with either other professionals who are skilled in that area, or we ourselves become more skilled in that area, and we start to again treat both things, whether it's depression and alcoholism or anxiety and methamphetamine addiction, whatever the case may be. We're treating both things concurrently and not separately, in addition to primary health care needs and looking at environmental influences. So co-occurring disorders are something that I think have oftentimes been relegated to, well, you have to go to that professional for that kind of service. And I think we have to get away from that and say, we're going to help you with all of this while you're here. And medication, too, can be a part of that. But blending our disciplines together, having a multidisciplinary approach to client care, having electronic records that communicate better amongst providers, and involving the client input, all of those things. CBT, again, I think most of you are probably familiar with cognitive behavioral therapy. It helps weaken those connections between negative sorts of behavior outcomes. In other words, when I see that drink, I know it's going to make me feel better. Those kinds of connections in the brain get very well established, helping to weaken those and strengthen other kinds of connections, like if I see a bottle of whiskey, I'm going to automatically start thinking about what that would mean to follow through with that thought, how I could avoid that, other kinds of options that would be more likely to result in a healthier outcome. And cognitive therapy teaches you how certain thinking patterns are causing your symptoms. It's a good way to phrase it. Again, in my mind, the behavior is a result of a primary brain disorder, not the other way around. So CBT attempts to help patients recognize and avoid and cope. Recognize, avoid, and cope. Avoid negative things. Relapse prevention. Let me just run through this and see what enhanced self-efficacy would be one area that I think is crucial to empowering the client to make good decisions on their own. Really helping them make those small accomplishments sometimes that show them I can still do something and do it well, or have a good outcome as a result of making the effort. The belief that clients can make change happen is necessary, and any way that we can find, even small ways, to help them recognize that ability is, I think, going to benefit the client. Sometimes it's a very little thing, sometimes larger things, but whatever is appropriate for that particular client and their needs. And relapse, of course, is a part of change. I think we oftentimes have viewed relapse in this field as a failure, as an indication that the treatment wasn't effective or that the client wasn't trying hard enough. A long time ago, I think there was a lot of emphasis placed on blaming the client for not being successful. But I think as we look at this as substance use disorders within the context of a chronic disease, we see that other kinds of chronic diseases, whether it's diabetes or heart disease, whatever the case may be, also involve relapse in terms of behavior. Anybody who is having to change their behavior in order to improve their health is going to go through this sort of, well, I'll do it for a while, but after I get feeling better, I'll fudge on what I'm supposed to do, whether it's taking insulin or a medication of some kind, or whether it's following a diet, exercising, whatever the case may be. But you find that when you look at it, you find that relapse for substance use disorders is really not any different than relapse in other kinds of behavior, returning to a former, less healthy behavior in other kinds of diseases. So we have to get away from blaming ourselves and blaming the client for relapse. It becomes a necessary thing to focus on so that we can get better at treating the illness. But really, relapse as a teachable moment becomes an opportunity to say to the client, relapse occurs for a variety of reasons. Let's find out what the reasons are for you and help you understand maybe better what some of the reasons might be that are leading to this cause. And then work with them on a sort of a mutual approach to how to deal with that. Challenge positive alcohol expectancies. Yes, we need to do that, but I think oftentimes, again, we're up against certain levels of craving and certain brain functions that make that difficult for a client. I think reinforcing that positive expectancies for drug use may not actually result in reward. Helping to reinforce that is certainly good. I think it's also not a bad idea to focus on what it is that they want to experience from alcohol and other drugs. What is it they're hoping for through that behavior? What is it they like about alcohol and other drugs? Because by understanding that better, we have a better chance of developing an intervention that matches that expectancy and finds a way to interrupt it. And of course, lifestyle balance, which is easier said than done. If you're working with somebody that's homeless, has a co-occurring disorder, other complicating physical health problems, then finding a lifestyle balance might be more of a challenge. Really dealing with Maslow's hierarchy there, I think. But, you know, to qualify that, going back to somebody you're working with on a long-term basis, that would be something you would obviously want to strive for. The ASAM criteria are one way to sort of monitor that as well, to see what parts of a person's life, what dimensions of health are out of balance for that person, and help them understand that as well. So these are the stages of change. I'll spend just a moment on them because I don't know if everyone listening is familiar with this, but Prochaska and DiClemente developed this model for primarily for alcohol and alcoholics. It looks at pre-contemplation where a person doesn't recognize a need to change, doesn't see a problem with the behavior at all. Contemplation would be somebody who begins to debate in their own head, is this causing me some problems? Do I need to change something about my behavior? Maybe just beginning to consider whether or not they should change something in relation to whatever behavior is being thought about. Preparation is when a person generally recognizes that the behavior is a problem for them in some way and begins to take steps to address it. It could be, for instance, looking up available treatment programs in their area that they could call if they wanted to, or looking for AA meetings in the area that they could maybe go to. Action is when they actually follow through with that thought and make arrangements to go to a treatment program or show up in an AA meeting or take some action to address the behavior. Maintenance is when there's been some stability and the behavior change has occurred. Obviously, maintenance is continuing with those changes that have occurred in hopes that they continue to lead the person in a direction of better health. When a person relapses during this change process, they may re-enter an earlier stage of change. That is, they may say, the hell with it, I've tried sober for 5 years and relapsed, what's the point? And they may go back to even a pre-contemplation stage briefly, or a contemplation stage where they don't, again, have that self-efficacy. They don't have that belief in themselves that they can make positive change and maintain it. So it can be a situation where people move around fluidly within these stages of change. I met with a psychologist, I worked with him a number of years ago, who, in his mind, he added a stage of change to this that was, it was called termination, which sounds, dreadful, but the idea was that some people, once they've maintained change long enough, the problem that they originally worked on to change no longer really exists for them. His reasoning was or his example was that somebody who quit smoking 20 years ago and really doesn't struggle with the idea of smoking again, really they've resolved the issue, and termination was his way of saying there's really no need for further behavior maintenance. They've already accomplished it and don't suffer from any lingering sorts of craving or other kinds of problems. That was his take on it. Cognitive restructuring, I think these are an example. It would be hard to stop drinking. I'll lose all my friends, be bored, things that we probably all heard, but valid concerns from a client perspective. So cognitive restructuring requires an assessment of the negative kinds or maladaptive behaviors and substance abuse beliefs that a client holds, and use Socratic questioning to help clients test the accuracy of their beliefs. I'm going to be honest with you here, and I'm not exactly sure what Socratic questioning is. If I've used it, I haven't called it Socratic questioning. But I think, yeah, I won't even venture at this point. I'll let somebody in the audience tell me what that means. Motivational interviewing, I won't go into great depth on this because you can look at the slide and it really pretty well explains in summary what motivational interviewing is. It's a very client-centered approach. It does involve the participation of the client. It's very non-judgmental. I think it improves the client's investment and treatment, and improves their self-efficacy and gives the client more of a voice and helps them to almost, through the clinician's guidance, walk into the solution themselves rather than have it told to them by somebody they maybe don't trust yet or have a good relationship with yet. So having that self-discovery, self-efficacy, and non-judgmental sort of response from the clinician, empathy and all those things, is, in my mind anyway, part of why this is an effective approach. See how we're doing on time. I'm going to try and get through all of the slides here without running over, and I want to leave some time for questions. So I'm going to go on here for about another 10 minutes and see how far I get. I apologize if I editorialize too much. Motivational interviewing, collaboration, evocation, and suggestion, autonomy, self-rule. So here are the 4 principles behind that. I've already sort of discussed, I think. Oh, developing discrepancy is an important part of MI, in that we help a client understand how their view of their situation maybe differs from the reality of their situation, doing that in a kind and authentic way. But it's the old, on one hand you tell me this, on the other hand this is what I see, and helping the client discover for themselves that there is a discrepancy between how they see things and what reality might look like. And again, sometimes we think we're using motivational interviewing when in fact we're not. It's actually a quite complicated approach, and it requires a lot of practice and a lot of self-reflection as clinicians on how we're doing it. There's just a human tendency to sometimes react to what a client is saying or doing without thinking about how would you respond in a motivational interviewing way. And it does take a lot of practice and a lot of skill. So it's not something just that you're being friendly and doing whatever the client wants you to do. It's a much more directive and thought-through process that I think, if you're already familiar with it, you know that. If you're not too familiar with motivational interviewing, really take the time to understand it and practice it. It'd be a good thing to review with a clinical supervisor after you've recorded a session or something of that nature. Behavioral health care, substance use, and mental health. A Venn diagram here that shows how the two intersect. I would add to that, if I could at the moment, another bubble for primary health care. Well, probably several bubbles. Oh, there's one. And I'll keep pushing this button because they keep showing up. So those things at least, and then probably environment, maybe including all of those things. I've spoken with physicians and other professionals in this field that know more than I do in certain areas, and the prevailing thought, that, as I understand it, is that the concern over whether the mental health disorder came first or the substance use disorder is really sort of, I don't want to say irrelevant, but the answer I'm getting from psychiatrists that I've talked to anyway, who are familiar with addictions is that let's treat the symptoms of what's the client's presenting at that moment and sort out as we go how to, or if we should differentiate how we treat a particular disorder based on whether it's substance-induced, or whether it's a separate existing disorder from previously. You obviously, I at least would want to talk to a psychiatrist familiar with both addiction and mental health disorders and their interaction to get guidance on this. But this mentions also the DSM-5, and I think there's some restructuring of how some mental health disorders are classified and diagnosed, but I haven't, to be honest, looked at the whole DSM-5 to confirm that. Just some examples or characteristics of co-occurring disorders. I have also heard that medications for some mental health disorders might not or won't be effective if the person is still drinking. At best, they maybe have a placebo effect. Differentiating between Axis 1 and Axis 2 disorders. Let's see what I want to point to here. All right, these are slides I'll let stand on their own here. If you have questions about them, send a message. I'll try and answer that. Okay, this kind of speaks to what I was just talking about. I don't want to sound like it isn't important as to the nature of the mental health disorder versus the substance use disorder, but they are occurring at the same time, and distinguishing which is more important to deal with is, in my mind, less important than dealing with both things concurrently. Just a second. General assessment approach for co-occurring disorders. I'm going to kind of rush through this a little bit. Reassess mental health symptoms at the end of 4 to 6 weeks of abstinence. I have, in talking with psychiatrists and other mental health professionals, I have heard that that's generally what they do to begin to distinguish where to focus their attention and how to treat each sort of disorder. There's a lot of programs right now that are billing themselves as co-occurring treatment disorder programs, and I don't doubt that most of them are, but I really think we have a ways to go in terms of developing our own workforce to better understand how to work with people with co-occurring disorders, and in working with primary care professionals. I'm just saying, as a field, let's be open to saying these are the areas we need help in, and welcoming that help. Is that it? That might be the last slide. Karen, can I turn it back over to you, or how would you like to do this for questions?
Yep. So thank you very much for that, Bob. And everyone, if you have any questions at this point, you can type them in the question chat box, and I will pass those along. Okay, so our first question is there a way to gain practice and skill in MI?
Yes. The ATTC network is a very good way especially for organizations and providers to bring in or disseminate information that's relevant to MI. And Karen, you can correct me if I'm wrong, but I believe the ATTC still does trainings, at least regional trainings for motivational interviewing. Is that correct?
Yep, that's correct. They have,
Okay.
yeah, regional trainings available from regional centers. So if that's something you're interested in, you can check out.
The other, oh, go ahead.
Yeah, that website. They also have online trainings as well.
Right. And so there's a variety of ways through the ATTC to get some knowledge and skill development. I think SAMHSA, CSAP maybe. Let me think real quick. Well, those resources, if you went to samhsa.gov, I think you would find quite a lot of information about motivational interviewing. The thing is that when you practice it, it's really important to either do this with a colleague or with a client, but record the session so that you can go back and review it with a clinical supervisor or a colleague and say, and you know, realize where did I go off track, where did I do it well, and that sort of thing. But really, you have to practice it. Bill Miller wrote a book on motivational interviewing that would be good to buy if you don't have it, and there are some. There's a tip manual on motivational enhancement techniques that I think offer some insight as well. But really practicing it and understanding it is the only way to get good at it.
Thank you. Our next question is, can you list a few motivational incentives you've used in the past that did not cost anything?
Yeah, I worked in Hawaii for a few years, and a much different culture, you know. And oftentimes what we would try and do, because we didn't have any money to spend on, say, gift certificates or gas vouchers or things like that, we would have meaningful sorts of low-cost either crafts of some kind or some sort of certificate or something that showed some care and thought and time went into developing whatever the object was. Whether it was in Hawaii, it was sometimes a locally, culturally significant kind of object, you know, something that maybe somebody could make themselves, or somebody on staff maybe makes themselves, maybe similar to a dream catcher or something of that nature, but an object that had some meaning. And when people did achieve some sort of behavior change, to really recognize it as professionals, either in a group setting or individually, really take the time to recognize it and make it more important maybe than what the client's expecting it to be. Make it a presentation and have it be have some time devoted to that. So really, it's in my mind, it's the level of thought that goes into whatever sort of object or token or symbolic gesture that you're making. It's the amount of time and effort and the genuine way that we present that to the client that makes more of a difference, oftentimes than the, say, monetary value or cost that went into it. That's been my experience anyway.
Thank you. Our next question is, what kind of parent training would you suggest in age-appropriate motivational approaches?
As far as family, I'll just say family instead of parent. Family involvement, to the extent that we can do that, first of all, it's a difficult thing. At least it has been in my years of doing work with adolescents. It's a difficult thing to involve families. Either they're fed up with their kids' behavior to the point where they just want you to fix them, or they're disenfranchised. The adolescent is really disenfranchised or not well connected with the family and doesn't want them involved in their treatment. But in the cases where you can have family involvement, what I've tried to do in the past and what I've seen others do that seems to work well is to educate them a bit about addiction, educate them as to what to maybe expect and what they need to do for self-care as well, and really for the overall good of the family. and which sometimes is difficult because it means they have to deny or not respond to the adolescent who is in trouble in some way. It's a very difficult fine line to walk sometimes. But helping the families feel supported in some way, giving them some information, just letting them know that some of what they're going through or most of what they're going through is normal, their emotions to it, their reaction to it, help them to also gain some self-efficacy around what they can do, what actions they can take, where they could go to get some additional help or support, who they can talk to, and that sort of thing. So really just providing an opportunity for them to talk, for you to listen, and then offer some real-life sorts of actions they can take to see to their own health and safety and those of other family members. As far as evidence-based approaches for adolescents, a while back I did some work with Dr. Schwiebel out of Arizona, and he was developing a curriculum called the 7 Challenges. And I haven't recently looked into that to see if that's still available. I know there was some cost involved in implementing that program, but it's an example, I think, of one particular effort to base stages of change and a motivational interviewing approach, basing that on the developmental stages of adolescence. And there are many others, I'm sure, now that I haven't kept up with. There are, again, tip manuals through SAMHSA that deal with specifically with adolescent treatment and what kinds of things are helpful or have been shown to be helpful. The other suggestion I would have for looking into that would be NREP. It's capital N, capital R-E-P-P. NREP is the National Registry for Evidence-Based Programs and Practices, and that might be a website to go to look for promising practices that are evidence-based practices that deal specifically with adolescents.
Thank you. Our next question is, can you speak to handling confidentiality when involving an adolescent's family?
Yeah, it depends on the state. I used to work in Iowa, and Iowa had a state law that said adolescents have the same rights to confidentiality as adults do. So when that was the case, and a 13-year-old came in or a 14-year-old came in for treatment, we weren't allowed by law, by state law, to communicate with anybody without that adolescent's consent. Same restrictions applied to that adolescent as they did for adults. Now here in Minnesota there's a different law, and federal law I believe says it depends on the state as to how they want to handle this. So in Minnesota we do require parental consent or guardian's consent for treatment. So in that case we would have to notify the parents or the guardian if an adolescent presented for substance abuse treatment. Beyond that, we would still adhere to the wishes of the adolescent in terms of who they wanted to know about their treatment status. But it depends on the state. The federal law, I think, gives the states the power to decide that.
Thank you. Our next question is, do you have any tips for new counselors on expressing genuine empathy?
Just be genuine. Try not to worry so much about coming across as an all-knowing professional. If you don't know something, tell them you don't know, or help the client become the teacher at that point. Really, it's an empowering way to build relationships with clients, is to, even if you know the answer sometimes, just to say, wow, you seem to know more about this, tell me more about this. Be yourself. You know, you probably went into this field because you have empathy, you have a genuine concern over the clients that we're working with. Just let that show, and try not to worry so much about saying the wrong thing or doing the wrong thing, you know, within reason. But allow yourself to be yourself and show that caring that you probably, I'm sure you have. Otherwise, you wouldn't be doing this kind of work. But I think people get hung up on oh, I have to follow this particular therapeutic approach, or I have to follow this theoretical approach, as it's written, and I don't want to stray from that, or I don't want to say the wrong thing. You'll get more comfortable as you do this longer, where you can let your guard down a little bit and just show who you are, show emotion, and people know when you're being yourself, and they know when you're trying to be a counselor.
Thank you. Our next question is, are there ways to adapt the treatment experience within the Western healthcare system?
To different cultures, I'm assuming?
I'd assume so.
I did have a chance to do some work with that in Hawaii, and also with when it was the Prairie Lands Addiction Technology Transfer Center. I worked with Karen and others on doing this. But what we did in the time that I worked on this was to really understand the culture that we were trying to work with. Understand that culture by asking those in that culture, especially elders and people of prominence, people that had respect of others within that culture. Oftentimes it was spiritual leaders too, and ask them, what do you think is a helpful, realistic way to approach this problem? And then introduce to them, here are some of the Western-based approaches to healthcare. How can we take the two things and blend them somehow, so that you can tailor a treatment program on something that's based in science, but also something that's based in the cultural norms of whatever culture that is. It's a very difficult thing to do, but where the elders and the spiritual leaders and the other consultants that you talk with, where they'll focus is on those things that have a commonality, and then you can start to look at what things both work in both cultures, and maybe just require a different language, different use of language, or a different body language, or whatever the case may be. Sometimes it's just a matter of adapting how we do things and how we say things, and what we focus on as important. We developed there's other more well-developed manuals of motivational interviewing as adapted to Native American culture. Gosh, I'm blanking on the names of that, and Karen probably at some point could help answer these questions. But there's a couple of efforts that have taken motivational interviewing instruction, that is how to train counselors for motivational interviewing, and have incorporated, I think this was Navajo, but incorporated Navajo cultural norms into that, and really showed the clinician, here's how you would generally approach a session with a Native American, in this case Navajo, and how that might be perceived by the client different, how it might be welcomed, I should say, more readily than by using a Western language and Western expectations and that sort of thing. I hope that's helpful. We did the same thing in Hawaii, where we really just stepped back and said, what's effective here? What kinds of cultural things influence health? How can we incorporate that into all of the things that we need to do for licensing and the stuff we have to do? How do we incorporate cultural differences into that framework so that we're not ignoring our licensor expectations, while at the same time acknowledging the real cultural differences that exist?
Thanks. Our next question is about the pharmacotherapies, and if you can describe some that are considered evidence-based.
Well, I'm not going to be an expert in this area. I did do a little work on medication-assisted treatment, and I hesitate to give too much of my opinion about this because it may not be accurate. But the drugs that I'm thinking of primarily for opioid treatment are Suboxone, buprenorphine, and methadone, that have, I believe, I believe, have been shown to be very effective in reducing relapse amongst opioid dependent people. In fact, the relapse rates go way down for those on some sort of either methadone or other maintenance program. But I would defer to mental health professionals, or I'm sorry, to medical professionals who have a better understanding of how that works and why that is the case. But I do know that the research anyway shows much improved outcomes, long-term outcomes for people who have struggles with opiates or opioids and tend to relapse rather quickly without medication assistance. With alcohol, I believe I've recently seen, or I have recently seen a study that shows that naltrexone, or it's the injectable version of naltrexone, I'm blanking on it. I'll think of it as soon as we're done, but there has been some evidence to show that that has been an effective method in combination with therapy to reduce craving and relapse amongst people with alcohol use disorders. Vivitrol.
There you go.
Yeah.
All right. Well, I'm not seeing any other questions at this time, so I think we'll go ahead and wrap up. So once again, I'd just like to thank Bob for sharing his expertise with us today, and I'd like to remind you all to please watch for our email with the handouts for this webinar. The attachments will include that CEU request form, your PowerPoint handout, and the GIPRA consent form. If you decide to participate in our GIPRA evaluation, we do appreciate that, as completion of those forms allows us to show SAMHSA the number of people served by our webinar. And to participate in our GIPRA evaluation, you'll return a signed consent form to our center by either email or fax. We hope that you'll be able to join us for the next webinar in this series, Basic Counseling Skills. That'll be presented by Kate Speck on Wednesday, August 17th. And then we finally just want to thank you for your time today participating in the session, and we hope you enjoyed it and look forward to hearing your feedback. So thank you so much.
Thank you.